Got it. Thanks everyone for attending, and welcome to yet another seminar as part of our series, Expeditions in Experiential AI. I know that's a mouthful, but this is our forum for featuring a lot of the great research and interesting work and problems that are happening at Northeastern by Northeastern faculty and leaders. And of course, I'll remind you every 2 weeks, we have 1 2-week period is the expeditions, which is internal. 2 weeks later, typically is a distinguished lecture series for an external speaker, which again will happen in 2 weeks from now. Today, we are very fortunate because we're going to be talking about a very, very hot and interesting topic, and really a topic of a lot of mystery for many folks, because it's important yet nobody understands what's going on. And this is algorithmic fairness in predicting opioid use disorder using machine learning. But of course, the notions apply to all sorts of other uses of the technology for determination of whether it's healthcare delivery or delivery of services or extensions or what have you. We are lucky to have Angela Kirby, who's at the Department of Economics at Northeastern University, and she specializes in health economics. The research focuses on health, labor supply, and welfare implications of the opioid use. Actually, she was mentioning to me that there was an excellent coverage happening at Wired magazine, probably the most recent issue, that actually exposed her work. And if you follow Angela on Twitter, she's been kind of retweeting from that journalistic reporting, and I think she will mention some of it in her talk. Her work ranges from research in fairness that arise in clinical algorithm situations to kind of preemptively identify people most likely to suffer from opioid use disorder, which is a very interesting prediction and recognition problem. She got her PhD in economics in 2016 from an institute across the river, MIT. Our president never likes to mention MIT, even though he graduated from there, but from MIT, and was a postdoctoral fellow in the aging and health research prior to coming to Northeastern. She is an affiliate member of the Institute for Experiential AI, which hosts the seminar series. So with that, I would like to turn it over to you, Angela. I'll monitor and collect questions, and we'll kind of cover the questions at the end. We'll reserve 10 to 15 minutes up to you and answer as many questions as come up from the audience. So I encourage everybody, type your questions in the chat, in the Q&A, and we will get to them. Thank you very much.
Wonderful. Thank you so much for having me. Sorry, just making sure the screen share is working here. Everyone can hopefully see the screen share. Please let me know if you can't see it. Yay, thank you. Wonderful. So I am just delighted to be here today to speak at the Institute for Experiential AI, where I'm a new affiliate member or affiliate faculty. Today, I'm going to be talking with you about my research on machine learning algorithms that have been developed to predict and hopefully prevent opioid use disorder among people who've been prescribed opioids for the treatment of pain. These are algorithms trained on rich patient medical history data that seek to identify people who may be at risk of developing problems with opioid use disorder. And the hopes of developing these algorithms is to guide clinical decision-making towards only prescribing opioids to people for whom they can be prescribed safely. That is the goal of these algorithms. And we're going to be talking about their development, use, implementation, and some of the concerns with the implementation of these into clinical practice. Okay, a brief history of opioids for the treatment of pain. In the mid-90s, opioids were rarely used for more than acute and cancer pain. They weren't used for chronic pain. But in the mid-90s, OxyContin was approved for chronic pain, and medical boards started to really worry that pain was being undertreated, given that there was a readily available therapy that could really alleviate suffering. So they began to encourage the liberalization of practices. This 2004 statement from the Federation of State Medical Boards is pretty illustrative. They said the state medical board will consider inappropriate treatment, including the undertreatment of pain, a departure from an acceptable standard of care. Apparently that got cut off. But it turns out that the scientific evidence on the benefits and harms of opioid therapy has lagged behind the shift towards the use of opioids. There are no randomized clinical trials on opioid therapy for chronic pain that have exceeded a year. And a host of sort of observational studies that are not randomized clinical trials have been conducted to try to understand these questions of how effective and safe opioids actually are. And broadly, they find that there's reason to question both the effectiveness and the safety of opioids for the treatment of pain. People who are prescribed opioids just look worse on a whole host of outcomes when you look at them in observational data. So the pendulum sort of swung backwards in the March of 2016. The CDC released new opioid prescribing guidelines saying that opioids are not preferred for chronic pain at all. And if so, you should limit the dosages. This was seen as a really abrupt and sort of stark shift away from prior practice, basically saying the thing that people had been doing since the early 2000s, they should stop doing, they should stop prescribing opioids for chronic pain. It was a pretty abrupt shift and received a lot of blowback that has continued to the present. The American Medical Association responded to these guidelines, essentially saying that they were devoid of a patient-centered view and any real acknowledgement or empathy towards chronic pain patients, which was pretty stark language. So this graph kind of tells the story of the opioid crisis in a picture. This is two things overlaid. The first is the prescribing of the volume of prescribing of all opioids over the past 2 decades, overlaid with the opioid overdose death rate. That's this purple line here is the opioid overdose death rate. And these lines are, or these shaded areas are the volume of opioids prescribed. As you can see, sort of from the 2001 to 2011 period, there was a 3-fold increase in the volume of opioids prescribed at sort of the whole societal level. This was associated with a concomitant 3-fold rise in the opioid overdose death rate. In 2011, sort of prior to the CDC guidelines, but as concerns were really starting to arise around the use of opioids for pain, there started to be a real pullback in prescribing. But as you can see, that pullback here, the sort of reduction in prescribing did not come alongside an effective reduction in the opioid overdose death rate. In fact, if anything, it began to accelerate. The reason for that is fairly well documented and sort of understood now through kind of journalistic accounts. Essentially what happened as doctors began pulling back on formal opioid prescribing through the medical system, patients and other people who used opioids began to turn to the illicit, sort of the illicit markets, the illicit system. And as the opioid prescribing rate came down, people started to take more heroin, which then became contaminated with fentanyl. And so as the pullback in prescribing has happened, there's been an increase in use of illicit drugs, which are more potent and more deadly, and therefore are driving an increase in the total opioid overdose death rate. So, the story, I think the reason I highlight this at the beginning of the talk is that the story of opioid problems, opioid use disorder, opioid overdoses are sort of complicated and complex at a societal level. There are multiple ways that a person can develop opioid use disorder. One is via what's called iatrogenic addiction, which is developing a problem based on drugs that you have been prescribed by your doctor. So this is developing opioid use disorder after you've been prescribed an opioid. But also people will receive opioids from friends, family, or on street markets. These are, and will misuse opioids that have not been prescribed to them. And then moreover, now there are, opioids just imported from other countries like heroin and other drugs that have been adulterated with fentanyl. These are not, really related to the medical system at all. So today we're talking about an intervention that targets medical prescribing. This addresses mostly channel 1, although it does touch channel 2 and channel 3 indirectly. So the backdrop of this paper is essentially considerable uncertainty that I think presently exists in the medical space over the appropriate use of opioids for the treatment of pain, exactly what the level should actually be. There's been this push-pull. There was a widespread undertreatment of pain. There was an increase in prescribing. And as that increase in prescribing led to a host of sort of social problems with abuse, there's been a really serious pullback. But at the time, it's sort of as this pullback has happened, pain patients have increasingly documented real harms to them in terms of receiving treatment for what can be debilitating pain. The Wired article that Professor Fayad mentioned at the beginning documents some of the sort of story. One of the things it does is it documents the stories of people who have been chronic pain patients for decades and some of the struggles they've had in recent years. And the development of these machine learning algorithms to try to predict and prevent opioid use disorder has been really motivated by the desire to sort of thread the needle to have both safe opioid prescribing to people who need it without causing inadvertent harm to people who might end up abusing opioids. So it's really motivated by a search for ways to identify patients who can be prescribed opioids safely without prescribing them to prescribing opioids to people who may experience harm. Okay, so preview of results slide. So I'm going to tell you what I did. What I first do is I successfully train a machine learning model that predicts opioid use disorder and hopefully will convince you that it shares many of the characteristics of opioid risk prediction models in the academic and commercial spaces that are in development. I'll characterize for you who is targeted by these algorithms, who the algorithms say should have their prescribing averted. I then take the scores produced by this algorithm and I stratify patients in what's called a quasi-experimental setting where opioid prescribing is reduced on a broad scale. Basically, I look and see what happens to these high score patients, these patients that the algorithm says should have their prescribing averted, and I see what happens to them. I see whether they are actually helped by prescribing being averted to them. And essentially what I will show you is that these risk scores don't correlate at all to the thing that we think we should care about, which is the benefits that come from reducing opioid prescribing. So high risk strata patients don't benefit more than anyone else. They benefit exactly the same amount to having opioid prescribing reduced. The algorithms don't seem to provide any value add vis-a-vis what clinicians are already doing. Back of the envelope calculations suggest that if doctors realign their prescribing to be more concordant with these algorithmic risk scores, prevalence of OUD might even rise, which is a very concerning result. And I will discuss fairness concerns that arise from who is most likely to experience the benefits and harms of these algorithms. Okay. So to start, just highlighting that there is a burgeoning literature that seeks to develop models that identify patients at elevated risk of developing OUD, in OUD being opioid use disorder. Early decision support algorithms looked for red flags in patient medical records, like visiting too many doctors or prescribers. But there's a modern generation of models that basically applies traditional machine learning approaches, applied on top of big health data, which can be medical claims data, it could be clinical data, it could be electronic health records, basically trains a model on these big health data sources to predict the development of opioid use disorder using machine learning and artificial intelligence. There's a recent systematic literature review I'm conducting with co-authors, and we identify 53 studies that train models to engage in this task. So train machine learning models to engage in the task of predicting opioid misuse, opioid use disorder, or opioid overdose. So this is a pretty large space. And some of these have been accompanied by the development of sort of clinical support tools that are implemented in various places. So there's been recent moves to deploy these kinds of algorithms as decision support for providers and insurers. So the main one is that the leading prescription drug monitoring program software provider, which develops software that is exposed to clinicians and prescribers and pharmacists when they are filling an opioid prescription, basically incorporates some proprietary risk scores into their prescription drug monitoring programs. What this means is that clinicians and prescribers and pharmacists are looking at this score before an opioid is dispensed to a patient. As was mentioned at the beginning, there's this recent journalistic account that does a pretty thorough job of documenting the emergence of the use of these algorithms in the proprietary space. As it turns out, a lot of this is proprietary, so it's a bit hard to know exactly what the prevalence of the use of these algorithms is in clinical practice. This has been true in other domains of AI in healthcare. There was a recent expose by I believe it was Stat News about Epic's use of a sepsis prediction algorithm, if I'm recalling correctly. These things sort of are not necessarily well documented or explained, and so you kind of learn about them in an ad hoc manner. But we do know for sure that prescription drug monitoring programs oftentimes incorporate an opioid use disorder risk score developed using a machine learning model in order to recommend to clinicians decisions based on that. This is specifically from the manual for that software. This is the Ohio Prescription Drug Monitoring Program. And this is what it looks like to log on as a clinician to see if the clinician is deciding, I would like to prescribe an opioid to this patient or not. They would log on and they would see a set of scores, and the machine learning based risk score here is this overdose risk score. And so basically they're saying that, this dummy patient, this fake patient, has seen many prescribers, has a lot of different prescriptions down here, and overall her overdose risk score is pretty high, which gives the clinician strong indication that perhaps they should not prescribe to Michelle Jordan, 76-year-old female. So what do I do? In order to try to understand the inner workings of the algorithms that have been developed to predict opioid use disorder, I use a similar data source to what is typically used for these exercises, which is commercial claims data from IBM MarketScan. This is a large commercial database derived from employer-sponsored insurance claims data, and it's used across a variety of contexts to predict opioid use disorder. In the literature review of the 53 papers that we uncovered that have done this task, a good healthy fraction of them use commercial claims data. What I have is an individual level panel drawn from large employers over the 2005 to 2012 period, and it has prescription drugs, inpatient and outpatient utilization, diagnostic codes, spending, procedure codes, et cetera, which can be used. These are clinical variables that can be used to gain insight into the patient's clinical record, and then of course the task being to use that clinical record to predict opioid use disorder. This kind of data is extremely rich, which is why people oftentimes come to it for these kinds of prediction exercises. How do I actually develop the algorithm? Again, I try to follow the kind of general approach that you see in the literature. So first, I construct labels of potential opioid use disorder using opioid dependence and overdose diagnosis codes, as well as prescriptions for recovery medications and claims that occur in mental health or substance abuse facilities. I identify about 22,000 people that in my data that have OUD, opioid use disorder. As you can see, this is a very, very, very imbalanced. This is a very good example of class imbalance, i.e. the sample is extremely imbalanced. There are very few people who develop opioid use disorder. Moreover, this is likely an undercount because many people with opioid use disorder are not necessarily disclosing that to their clinicians. So essentially, we have a small number of people who are positive on the target variable, and they're probably an undercount from the real from the real world. But nonetheless, all of these flaws are typical of the literature as it stands currently, which uses similar sources of data. The features I train on include demographics and a host of clinical variables, including diagnosis codes, which are, again, clinically related variables of what your diagnoses are, the types of facilities you attended, the type of provider seen. This adds up to over 1,000 features. I select my cohort again per the typical approach in this literature, which is by selecting opioid naive patients with no prior opioid use disorder diagnosis. And then I train the model on them. So these are people who have been prescribed an opioid but had no opioid in the past. And I use a standard, fairly off-the-shelf machine learning algorithm that tends to do well in this kind of data, which is gradient boosted trees. So first, I want to walk you through the features identified by the algorithm as most important. This helps us sort of understand who is most likely to be, who the people are that are receiving high scores here. The first thing to notice is that there are several demographics that pop up as important: age, gender, industry, and some things like place of service, which is receiving treatment in a military treatment facility. More interesting, I think, is the very high prevalence of pain conditions popping up, or evidence of pain conditions. So everything from having disc disorders, back disorders, lesions, cervical region, provider pain management, chiropractors. It's just all throughout this, you're seeing sort of what looks like the variables that predict who's likely to have chronic pain are the people who are being picked out by this algorithm. What the model is overall telling us is that aside from some demographics, the main characteristic associated with opioid use diagnoses after receiving an opioid prescription is sort of a constellation of chronic pain conditions and chronic health problems. The people at highest overall risk of being diagnosed with opioid use disorder are people with chronic pain and other health issues. There's also some evidence of, remember, we excluded anyone with prior opioid use disorder, but it does seem like perhaps there are some people with undiagnosed opioid use disorder that are also scoring high on the algorithm. Okay, so next is model performance. Standard thing to do in this literature is visualize the receive your operating characteristic curve and calculate the area under the curve. In both of, in my test sample, as well as, we'll just focus on the test sample, which is the top left-hand corner. The AUC is high. This is characteristic of this and is driven by the fact that the sample is highly class imbalanced. So because the sample is highly classed and balanced, it's easy to get a high AUC because essentially most people are zeros, and the algorithm correctly says that most people are zeros. Most people are negative for opioid use disorder. And the model gets that classification correct in the vast majority of cases. On the right panel is the precision recall curve, and what you can see there is that the precision of these models tends to be very, very low, no matter the threshold chosen, and I'm about to dive into that. Okay, so let's think through these results in a little bit more detail. If we set a threshold at the 99th percentile of the score distribution, we would get 7,640 true positives and 61,255 false positives, which gives a precision of 11%. So just to highlight this, if you were to implement this into clinical practice and set the cutoff at 99th percentile, you would be saying that only about 10% of your targeted folks who you've reduced their opioid prescribing would actually have gone on to observably develop opioid use disorder. So this is a very low precision rate. I think that this is an important sort of clinically relevant result, because it sort of shows that even using these advanced methods, you're only about 10% of the time correctly targeting somebody in your targeted sample. You also would miss the majority of your positives at this 99th percentile. You would have 7,640 true positives, but 13,231 true positives who are misclassified as not developing OUD. Those are false negatives. This gives a true positive rate or a sensitivity of 37%. At the 95th percentile, you would identify 15,000 true positives and 328,000 false positives for a precision of 4.5%, and 5,000 positives would be misclassified as false negatives. So in this case, you're getting pretty good sensitivity, but your precision is very, very low. For both thresholds, again, to hammer home, the vast majority of the people in the sample, 6.5 million, are correctly classified as true negatives. And so therefore, sort of the AUC and specificity are quite high. And why did I pick the 95th and the 99th percentile? These thresholds are commonly picked across the literature as sort of good thresholds for where to set your line. In the proprietary algorithm that's been deployed by the NARC score guidance, they use these thresholds. They basically give thresholds that correlate to the 95th and the 99th percentile. Just as a note, the algorithm does a good job of stratifying risk by kind of what are used as traditional metrics that are often reported, and especially in the public health literature. The odds ratio of being diagnosed with OUD is 500 times the 10th decile and the first decile, i.e. it does do a good job of stratifying your probability of developing opioid use disorder. I'm getting some questions, and I think I want to wait to the end, unless.
Yeah. Please wait.
Okay.
Please wait, Angela.
Awesome.
Sorry, this is Osama.
Great. No,
I'm also
great.
guilty of posting questions, but
Yes,
I just want to encourage everyone to type in your the questions, and at the end, Amanda will step in and kind of organize them by importance and order received.
Awesome. Thank you so much. Yeah, and thank you everyone for the questions. I look forward to actually digging in with them. All right. So there's a recent review of 5 OUD prediction algorithms that sort of found similar characteristics across the space. So they find precision from 1 to 15%, sensitivity up to about 15%, and specificity from 90 to 100%. This was of sort of older algorithms. We're doing a systematic review, as I mentioned, and that will be published hopefully relatively soon. And what we find is consistently high AUCs. So what we find is similar to the AUCs reported in the literature, but really wide ranges of reported precision from less than 1%, literally less than 1%, to over 50%. One of the key goals that we've had is detangling why precision seems to vary so much. Oftentimes it's not reported at all, or it's actually just directly miscalculated. But there's a wide variation arising from what features the algorithm was allowed to train on or look at. Oftentimes, variables related to opioid use disorder or substance use disorder are allowed in the feature set, and that gives higher precision. And then also oftentimes precision is being reported on data that has been rebalanced. So essentially, so that there's not such a degree of class imbalance, which is unfortunately not realistic to deployment in the real world. So the degree, one thing I would just want to highlight is the degree of class imbalance of the sample is basically the kind of key determining factor of what these variables tend to look like. That's sort of my assessment of this literature. If you are predicting the opioid overdose, which is an extremely rare event, then that's even more class imbalanced than opioid use disorder, and this varies across samples. But essentially, model performance, the kind of key driver, often in my assessment, is just directly related to the degree of class imbalance of this particular sample and target looked at. Okay, so moving on to fairness concerns. So to consider fairness concerns, I first follow a simple model drawn from a paper in this literature, Hastings et al. 2020. They write down a very simple decision framework where they say that the costs and benefits of implementing an opioid risk policy or an opioid risk algorithm into clinical practice should balance the harms to people who are averted an opioid to treat their pain with the benefits to an individual in society of averting an opioid use disorder outcome. So given true positives are approximately 10% of all positives, what this means, what this framework implies is that opioid use disorder must be 10 times the cost of not receiving an opioid to treat pain. Oftentimes in this literature, including the Hastings paper, there's sort of a notion that the cost to an individual of not receiving an opioid to treat pain is low and the cost to society is high. But that is something that's sort of, I would say, again, relates right back to the motivation of this talk, which is that that's quite in dispute. I have work myself that shows that reduction in prescribing causes pretty significant reductions in ability to work and sort of other outcomes for pain patients. So that there are potential real meaningful costs here, although benchmarking the costs of opioid use disorder versus sort of the harms of not receiving an opioid is something that I don't think is fully settled, because obviously the costs of opioid use disorder are also extremely high. But critically, this model and most models in this space assume that the true positives are, in fact, sort of, if you avert prescribing to the true positives, to people who are labeled high risk and would have an adverse outcome, that they will actually prevent that adverse outcome. And therefore, so every time you avert a prescription, you are therefore averting opioid use disorder. And that is the motivation of the remainder of this talk, to sort of investigate that question. Is that actually true? If just to run through a little bit of the math behind this, if the goal here is to inform clinical decision-making, the goal here is not to identify your baseline risk of developing opioid use disorder, but rather your heterogeneous treatment effect of receiving an opioid, sometimes also called the conditional average treatment effect in this space. Using a simple model, we could say that if you are prescribed an opioid or not, your outcomes, whether or not you have an opioid use disorder diagnosis or not, are going to depend on two things. First, what was your baseline risk regardless of receiving this prescription? And second, what is your heterogeneous treatment effect of that relates the decision to receive an opioid or the receipt of an opioid to a higher probability of developing opioid use disorder? And what the literature sort of, I think, implicitly seeks to identify is this heterogeneous treatment effect. But in fact, the setup of these algorithms is not set up to do that. How does this typically map to what's actually done? Typically, people do not train their models on a full sample of people who are prescribed or not prescribed an opioid. They don't look at people who have DI of 0 and 1. Instead, they just, because of the fact that this would suffer from severe selection bias and who receives an opioid versus who does not, this would create lots of problems. What they do instead to address the selection problem is just shut down that channel entirely, and instead just look at people who've received opioid therapy to look at what the characteristics are that later predict the development of opioid use disorder. This shuts down that channel that would contaminate things via selection bias, and instead estimates what amounts to the likelihood of receiving opioid use disorder if you've received, or the likelihood of developing opioid use disorder if you have been prescribed an opioid, which is comprised of your baseline risk, which is determined by your individual factors, as well as your heterogeneous treatment effect, which is determined by individual factors. So this algorithm will work well as long as your heterogeneous treatment effects, your conditional average treatment effects, are strongly correlated or sufficiently correlated to baseline opioid use disorder risk. Basically, what this is saying is that if people who are at high overall risk of receiving opioid use disorder also are the people who are going to most benefit from having their treatment averted, then this algorithm will work fine. But I don't think there is any a priori reason to expect this. And in fact, what I'm now going to investigate is whether or not this is true. So, many dimensions of algorithmic fairness have been explored in recent machine learning literature. Obviously, this is a massive space at this point. The dimension of fairness I'm considering here is bias generated by inappropriate choice of the objective function, where we have a model to predict overall risk, but to inform clinical decision-making, we wish to only estimate the heterogeneous causal treatment effect instead. And it's worth noting that the algorithm might perversely increase a provider's confidence in prescribing an opioid to a person in a low baseline risk group if the machine correctly says they're in a low baseline risk group, even if they may have a relatively large heterogeneous treatment effect. So by training on the wrong objective function, you may find that you're both sort of denying treatment to people for whom there is not a lot of benefit, and also giving more treatment to people for whom there is a lot of harm. And in terms of sort of thinking through the fairness concerns, unfortunately, many of these clinical databases that are available to researchers don't have classic variables like race to look at. They do have gender, and they have some indicators of socioeconomic status, but they're not wonderful. But what we can see just from our feature importance table is that we see that people with high baseline risk scores have complex health concerns and chronic pain. Therefore, we expect that they are probably fairly likely to be somewhere on the disability spectrum, or they're more likely to be somewhere on the disability spectrum. So when I'm thinking about fairness concerns here, I'm thinking specifically about concerns around not only our traditional concerns, but specifically around the effects on people with disability. There are other major concerns that might be looked at with an appropriate data source, but unfortunately, I don't have that data source. All right, so what do I actually do to investigate this potential mismatch? I turn to a setting where I nest my opioid use disorder risk score model into a quasi-experimental setting where there was a large and lasting broad-scale reduction in opioid prescribing that hit most pain patients. This relies on my pre-existing work, which documented that specifically that the timing of the implementation of prescription drug monitoring programs is sort of, they came in and they were phased in, and the timing in which they came online was sort of broadly a quasi-random or quasi-experimental. And I basically use that natural experiment, which is something that we use a lot in the field of economics. I use that natural experiment to investigate the impacts of a reduction in prescribing stratified according to the machine's predicted risk score. What do? As I said, I investigate the impact of these laws on both prescribing and on outcomes, stratified according to what the machine says, the groups that should have been averted prescribing and the groups that should not have. This framework, I'm not going to go into this, but if this were an economics audience, I would. The framework is a classical difference in differences quasi-experimental framework for studying the impact of an external intervention on people. So the first thing I want to show you is that the experiment we're studying reduced opioid prescribing in a lasting manner. This goes out for 4 years here on the right-hand panel. And in order to think through the magnitude of reductions throughout the rest of this talk, what I do is I calculate the relative risk reduction, which is essentially the effect of the intervention divided by the pre-period mean. Because all of these things are very rare events. Getting prescribed an opioid is rare. Getting an opioid use disorder diagnosis is rare. So essentially, I calculate the relative risk reduction to think about in scale what's going on. So what this means here on this panel here is that when this experiment happened, in places where this experiment happened, to patients for whom this experiment happened, on average, there was about a 3.5% reduction in their likelihood of receiving an opioid. Second, this intervention, which reduced broad scale prescribing at the societal level, really reduced prescribing for everyone. We see also an impact, a lasting impact on the development of opioid use disorder. The relative risk reduction there is around 8.5%. So the next thing I do is I stratify my sample into two cohorts according to their risk scores. I use the 98.5 percentile to divide people into two groups, what I call the targeted group and the non-targeted group, for sort of a simulated policy experiment, where the targeted group is allowed to receive opioids and the the targeted group is averted opioids and the non-targeted group is allowed to receive opioids. They're still given the green light. First, I look at the probability of receiving opioids across the targeted and non-targeted group. And I find that in fact, the risk score does in fact seem to correlate to what doctors are actually doing when they are subject to this experiment that's telling them they should reduce their opioid prescribing. When doctors are told to reduce their opioid prescribing, the targeted group with the high risk scores is the group that sees the higher reduction in the receipt of opioids. But interestingly, I find that their relative risk reductions across the targeted and the non-targeted group are extremely similar and not statistically different. They each see about a sort of a 6 or 7% reduction in their relative risk reduction in terms of developing opioid use disorder. So even though the non-targeted group had a lower reduction in their likelihood of receiving an opioid, their reduction was similar. So how do we think about this in context? So to highlight sort of how a policymaker might think, we could consider implementing an opioid reduction policy, and we have to choose one of the two groups. First, let's take aim at the group that had the high risk score, the 98.5 percentile group and above. If they were to target that group, they would be able to avert 2,800 cases of OUD. If they took aim, though, at the less than 98.5 percentile group, although it's a much rarer event with a much lower sort of absolute reduction, because it's such a larger group of people, the people in the 98.5 percentile and below, that's about 52 million, it's 52 million person quarters, they would avert 2,800 cases, which is essentially the same amount of cases. This motivates the calculation of an implied treatment effect in the last line of the table, which is that if anything, you're getting more bang for your buck in this non-targeted group. What might this be caused by? So the way I sort of think about this is these are our chronic pain patients. These are people who have really complicated conditions and comorbidities. Yes, by reducing prescribing, you can reduce adverse events. What's going on here? These are people who receive opioids at a much lower rate, but are still potentially susceptible to opioid use disorder events. So particularly, this is people who receive, opioid prescribing for perhaps they broke their arm or they had their wisdom teeth removed. Especially in the earlier part of this decade, they would often receive very large opioid prescriptions that were probably inappropriate. So when this experiment came in, reduction in that group actually had a lot of bang for buck. Basically, people who had sort of acute conditions where doctors really tightened up their prescribing, you actually had a pretty big bang for your buck. But the algorithm would never have told the doctor to worry about these people. The algorithm says only to worry about your targeted group. So in order to visualize this effect, I then do the same exercise, but across 10 risk strata. Basically, this is just, again, bucketing people into 10 groups as opposed to 2 groups. And for receiving opioids, again, you can see that the people who had their reduction, or their prescribing reduced, that those people were more likely, according to sort of doctors and the algorithm basically agree. People with high risk scores had their opioid prescribing reduced at higher rates. But then if you look at their outcomes, you see absolutely no effect. The relationship between the predicted risk score and the heterogeneous causal treatment effect as estimated inside of this experiment is exactly 0. Basically, the line is completely flat and statistically quite close to 0. There's no relationship between the score and improvement in outcomes. You can also do the same exercise, but bucketing differently into 20 algorithms, and you really find the same thing. The relationship is basically nothing. So to wrap up, I trained a machine learning algorithm to predict opioid use disorder that mirrors many currently being deployed. The social value of deploying these algorithms into clinical practice in order to inform clinical decision-making by doctors and pharmacists will depend on whether the estimated risk score is correlated with the heterogeneous treatment effect of receiving an opioid. The cost of misclassification, both false positives and false negatives, are also very relevant to the calculation of social value. So you need both of these pieces. I then plug my machine learning based risk scores into a quasi-experimental setting to see whether they seem to correlate with heterogeneous treatment effects in a situation where opioid prescribing was broadly reduced. And I basically find that there is no relationship between these scores and what appears to be the heterogeneous treatment effect. If anything, given the implied treatment effect, it implies that reallocating towards away from people with high scores and towards people with low scores could even worsen the situation potentially. So this, I hope, adds to the literature on the many and varied forms of algorithmic fairness. Here, this comes from the choice of objective function. The fairness concerns that need to be investigated are who is targeted by the algorithms and whether they have large clinical harms or benefits. There is a burgeoning literature in both econometrics and economics and machine learning to try to directly investigate the conditional average treatment effect or treatment effect heterogeneity. And sort of modifying traditional approaches. I don't yet have an opinion on the promise of this, but it definitely solves some of the main concerns identified here. You know, again, this is not the only space in which these kinds of concerns have been raised. Other, you know, investigative reporting and other research has documented problems of this kind across the sort of clinical prediction space, and I think is relevant for any task which it seeks to inform clinical decision making using AI and ML models.
So hopefully you will all join me virtually for thanking Angela for a very interesting talk. Let me start handling some questions, and then I'll turn it over to Amanda for further questions that came online, etc. One question. Well, let me ask. Maybe with one stone we can hit two questions. My own and Ian Paul's question. So, is there data on how well human experts, like a physician or a practitioner who really knows what they're doing, in terms of like what is their you know, precision recall curve, so to speak, you know, what's their operating point?
Right.
And often in these problems, you know, I've found there are areas where algorithms perform just as well as humans and everybody's in a bad zone, or humans are way better, which means potentially they're utilizing intuition, which means also, to Ian's point, they're probably looking at other variables that the algorithm doesn't have, is not privy to, like maybe the disposition, or, you know, nervous tics, or, you know, the color in the eyes, or something where that human expert picks up on it, and it allows them to have so much better performance. So I guess the first part is, do humans perform much better than what you've shown? And second part is, what do we do about getting those additional variables so we can get the performance, you know, game changer?
Yeah, so that's a really, really interesting question. And I think this is a very interesting space for that question, because actually, I think that there's quite a lot of documentation that physicians also are not great at this. So there's actually a very interesting line of literature from a while ago where people argued that essentially that physicians were protectively racist in the prescribing of opioids. Essentially, they would sort of just like not prescribe opioids to people of color or people who were poorer. I have some related work that shows that people are just really not even receiving opioids much in the Medicaid program at all, which is the program to give social or to give insurance to the poor. So basically, we know that physicians are making these judgments probably which are largely informed by their own social biases. We know that women have surprisingly high rates of opioid use disorder. This may well arise from the fact that women were prescribed opioids more freely because doctors think, oh, they're women, they're not criminals or whatever. So basically, we know that I don't think doctors have a great insight into this. That's sort of my own personal view. The decision support tools to give a more data informed answer, the decision support tools that were studied in the Ruff et al. Paper were largely older decision support tools, which just were given to clinicians based on really rough, like kind of red flag things, which I think those go back quite a long time, and those kinds of decision support tools have existed for a long time. They also have the same characteristics, i.e., I think that essentially it's just incredibly hard to know who will end up struggling with opioid use disorder. There's a lot of really intense biological or sort of important biological factors that go into whether you like opioids and whether or not you want to abuse them. And that's not something that's easily observed by clinical data. It's not easily observed by an interaction with a patient. You might have some indication from family history, but I think that the overall answer there is that nobody totally knows what to do. I think clinicians are about as good as the machine. And I'll also highlight for you that, in my own results of this broad scale reduction in prescribing, that broad scale reduction in prescribing seemed to hit most people and was essentially clinician led. So clinicians were basically being told, you really need to bring down your prescribing. And the results of that were that people who looked more complicated and had pain conditions that looked bad according to the algorithm, as well as the doctor sort of made the same judgment, they saw their prescribing reduced, but they didn't have lower rates of OUD than any other group afterwards. So I think doctors are doing, okay, but there's a lot of problems with how this is done by doctors as well.
Okay, great. To answer a quick question here, we do the recordings of all the talks are made available, so you can always find any past talk, including this one, on our website for the series of seminars. Amanda, over to you with further questions, please. And feel free to stop sharing the screen if you don't need it, Angela, up to you.
Yeah, although it's possible I would want to answer with this slide, but I'll stop for now so it's easier to see me.
Hi, Angela. Thank you so much. That was such a fascinating presentation, and I found myself my mind was racing with questions as you were speaking. So thank you for that. I wanted to ask you a question from myself. Did your model, when you said that they factored in, when they actually discovered the people who measured as actual OUD people, like you said, that was a very low number, opioid use abusers. Did it also factor in any previous history of addiction with those people, and how or where they ranged on the susceptibility scale?
Yeah, okay, well, I'll try to answer your question. I'm not totally sure I understand. So basically the way that these studies are often set up is essentially the ideal experiment in mind being, we want to take people who are not OUD, they don't have opioid use disorder. We want to look at what happens when you give them an opioid, and then we want to see who develops opioid use disorder. So essentially a common setup is to say, let's take a cohort, let's exclude everyone with opioid use disorder. And then let's look at people with initial prescriptions. So essentially the entire sort of structure is set up so that you have what are believed to be opioid naive or opioid use disorder and opioid naive patients. And then you study what happens to that cohort when they receive an opioid. So the answer is often no, but studies are set up differently. And so some studies do actually keep in the sample people who already have histories of opioid use disorder. They are the studies that tend to have really high precision, because essentially what you have is somebody has opioid use disorder, they receive a prescription, they still have opioid use disorder. You can't see intensity or anything like that. So essentially you're basically finding that people who had opioid use disorder before getting a prescription still have it after, which increases your model performance a lot, but I'm not sure is useful clinically because a clinician would already know that that person has opioid use disorder.
Okay, and so in that case, when you say you take people that do not have the opioid use disorder as to start the study, do you know if they have, let's say, if they're smokers or if they're regular drinkers or if there's any history of addiction? Is that something that you factor in at the start, or is it become irrelevant?
Yeah, so so those are visible in as much as they are in the data, and a history of sort of alcoholism or other things would be visible in the data if it was diagnosed by a clinician and sort of provided, it basically, if it ends up in the claims data, then it's visible. Yeah. So that would be in there.
Okay, great. I believe Joe Fitzgerald, you had a question that you wanted to ask. Do you want to unmute?
Yeah, thanks, Angela. Really appreciate you covering this topic across so many dimensions. I wonder if you had 5 minutes, I've heard that something like 1% of doctors prescribe 50% of the opioids in this country. If you had 5 minutes in an elevator with that doctor, what would you say?
Oh, goodness. I would. That's so hard because that's an interesting question. So my view on this is that there was a large amount of really, really bad clinician behavior that occurred in the 2008 to 2013 era. There were pill mills in Florida that were just writing scripts frequently. There was a lot of really documented bad behavior. A lot of those people have been arrested, to put a very fine point on it, or have been under investigation or lost their licenses. A lot of that has really stopped, and a lot of that's reflected in the overall social prescribing data. I am sure there are still abusive clinicians, although I bet your statistic might come from an earlier era. And sort of to counteract that, many clinicians now have dropped their pain patients. And so now mixed into the group of abusive doctors are doctors who are pain specialists, who are some of the very few doctors who are willing to see pain patients. And so that is also creating a long tail effect, because essentially you've got a small number of doctors who are still willing to see patients who are prescribed opioids. And if they're and then other doctors are dropping. And so the high volume doctors, some of them are some of the only people in an area willing to prescribe opioids at all. So I don't know what I would say to them, because maybe I wouldn't know which type of doctor they were. But I have some empathy for the second type of doctor.
Excellent, thank you. I see Daniel has asked a question. Daniel, would you like to tell us your question?
If I can. Yes, I see you've unmuted me. Thank you. I happen to be aware that some of the decision support tests that have been done at Stanford at the VA. And I'm wondering, could the VA data be available for this kind of research? And might you get some different results than what you get from the general population?
I would absolutely, if you would like to send me if you would like to introduce me, I would absolutely love to collaborate with people on VA data. And yes, it absolutely might be different. First of all, the VA has better data because it's a
Yes.
socialized medicine. They would have some of those, they have EHR data, they just have a lot more data that could potentially create a richer algorithm that actually does pick up on an informative signal. That is completely possible. My belief is that essentially but I do think that the kind of core problem here is that what you need to believe is that baseline risk correlates to heterogeneous treatment effect. And that's visible to the algorithm. And if it does, then the algorithm will work okay. And if it doesn't, it won't. And I think that whether or not you have really good data, and I think good data could help, whether or not you have good data, the objective function problem remains. And so essentially what you need to do is nest the training of the algorithm, or you need to nest the testing of the algorithm into some sort of experimental framework where you can find out whether it's doing a good job or not.
Yeah.
I would believe it, when I set out to do the study, I didn't know what I was expecting to find. This is one of those nice studies where you kind of either answer is interesting, I think. So, I think it would be great if it turned out that there was a domain where this works well. But I do think that the objective function problem is really important. It's also possible that they could do a more sophisticated, like importing some of the machine learning approaches to estimating heterogeneous treatment effects directly, that perhaps they should try both and see what happens. I think that would be really, really interesting. And yeah, I would, I think that is really important and people should be doing that work, whether it's me or somebody else.
So, Angela, since we're hitting time, I want to make sure that we kind of end on time. One quick comment on the VA. We absolutely have the best data sets and settings possible. However, they are very, very restricted on sharing it, and even worse, some of the results, they would not, maybe insights and results allowed to share because they view that as tied to, military secrets and national security and all that kind of stuff. So it's unfortunately one of those amazing treasures that remains untapped to this day. They would welcome you to do it inside their fences if you're willing not to share the outcomes, which makes it very tough.
Yeah, I had one of my early career heartbreaks was trying to set up something with a colleague who's in the military health, or he's basically a professor at West Point, and we tried to get access to this data to do this, and we failed. So I've been burned too.
Yeah. So wanted to thank you very much for the talk once again. I'm sure there's plenty more questions. I actually have a couple, but I will ask them offline, having to do with fairness and justice. And maybe we'll do that with a discussion with David Lazar and a bunch of others who worry about these things also. I urge, thank you everyone for attending, and please stay tuned, and we'll see you at the next seminar. And of course, the recording will be made available because we realize most of our audience can't make this time. So everybody attends the recording, and we collect that data. Thank you very much, Angela.
Thank you so much.
All right. Bye-bye.
Thank you.